So today we are going to talk about psoriasis. So to me, a 20-year-old male came with a complaint of plaques. He said that he is having thickened plaques over the scalp, over the lower back, knee and elbow. When I saw those plaques, they were salmon pink in color and having scales which were silvery white and in shape. He was worried it might be an infection he has got from someone. But it is not an infection, it is a case of psoriasis. A case of psoriasis presents with plaques. So, as we know, plaque is a elevated skin lesion which is usually flat topped of a size greater than or equal to 0.5 centimeter, but in some books it is written as 1 centimeter. Psoriasis has a chronic course, but its course doesn't look like a straight line. It is a relapsing and remitting course where the relapse is usually in the winter, and this disease has seasonal variation with exacerbation in winters. So psoriasis is a kind of inflammatory disease which can involve the skin, joint and nail. This disease increases the risk of cardiovascular events by approximately 2.81 times. So this disease has a few triggers which we have to know about. So this 20-year-old guy is a fat man who smokes and takes alcohol regularly, and he is in a lot of stress from his job, and all of these are trigger factors for psoriasis. A model 21st century worker, a lot of stress from job and marriage, who is fat, smokes and takes alcohol. So elevated BMI, smoking are very strong factors for psoriasis, and alcoholism or taking alcohol, pregnancy are also factors. Psoriasis is not an infection, but infection can trigger it. A streptococcal throat infection can go into psoriasis after a few weeks, which is a usually a gutted type of psoriasis, which we will discuss in a few minutes. HIV is also associated with psoriasis, which becomes an erythrodermic or severe form of psoriasis, refractory treatment, which we'll be discussing in few minutes. Psoriasis also have a genetic basis. It has multiple genes related to it, like in diabetes. So there is no clear-cut monogenic or Mendelian inheritance of psoriasis. That is, it is not a genetic disease. There are multiple genes involved in it, like in a diabetes. But like in a diabetes, there are also monogenic form of psoriasis which are now getting established. Few genes which you can remember are important for susceptibility of psoriasis are SORAS1, which is related to HLA-CW6, and SORAS2, which is related to CARD14, one of the reasons of monogenic psoriasis. This gene mutation causes activation of NF-kappa B, which we might know causes recruitment of inflammatory cells. So we can discuss about psoriasis one by one, and we can see each component of psoriasis one by one and understand how this disease usually presents. So in the skin, psoriasis presents with three basic components, which are erythema, which is redness, induration, and scaling. And we can also correlate these manifestations in histopathology, which we will see in a while. So this erythema is actually salmon pink in color. However, this pinkish color is only seen in possessions, and it is not appreciated in skin of color. SOC means skin of color. Induration just means thickened plaques which are salmon pink in color, and scaling is silvery white scales which are silver in colors. These scales are not fine, neither they can be actually they are actually layers. So we have layers of scales, and these are also called candle wax, uh, correlated with candle wax appearance, like a scraping of a candle. Silvery white color is due to the air scale interface which happens. So the reflection of the light because of this interface causes this silver white color. So what happens in psoriasis? There is a localized milieu of area where there is a lot of pro-inflammatory cytokines. In a small area, there is a lot of pro-inflammatory cytokines which causes increased cell turnover, and with this increased cell turnover, there is thickening of this epidermis and rapid shedding. So skin sheds in layers which appears like scales, and this thickening of the skin appears as a plaque. So what are the sites which are involved in psoriasis? The sites which are involved can be remembered with a single word: extensor surfaces are involved, including the knees, the front of the knees, the front of the elbows, as well as the lower back or the lumbosacral area or the gluteal cleft, and some difficult to treat areas including the scalp, the palms and soles, and sometimes even the groin can be involved. Another area which can be involved is umbilicus. So what happens in this pro-inflammatory cytokines, which cytokines are increased, is important to understand the treatment of psoriasis, because there is now a lot of role in targeted therapy in which specific cytokines are targeted. So we have to know the pathogenesis in a very brief or simplified manner. So the pathogenesis of psoriasis is very simplified. What happens? Some unknown epitope triggers the dendritic cells, which releases IL-23 and IL-12. IL-23 activates Th17 cells, which releases IL-17, which is one of the important cytokines causing psoriasis, and IL-12 activates Th1, which releases IFN gamma and TNF alpha. TNF alpha activates the dendritic cells, as well as it is also an important cytokine which causes the, and IL-17 and TNF alpha are the important cytokine which causes the psoriasis. So in this we can also see one corollary or similarity. If you remember, even the pathogenesis of TB appears quite similar. So macrophages in TB, activated by the TB epitopes, releases IL-12, which activates the T cells, which releases IFN gamma and TNF alpha, and which can activate the macrophages. Remember, dendritic cell are type of a myeloid cell sequence. So these cytokines, including this IL-23, are important cytokines for the pathogenesis of psoriasis, and they are targeted for the treatment of psoriasis. The clinical subtypes are, one way to classify are type 1 and type 2 psoriasis. Type 1 psoriasis occur in young patients associated with HLA-CW6, which we just remembered is correlated with this gene susceptibility region, and it has family history present, while type 2 has none of this. Otherwise, they are classified, the generalized types are classified as chronic plaque psoriasis, which we have discussed, flexural psoriasis, which actually involves the flexure areas. So the areas of the axilla, the groin areas are involved. So here the scaling is less due to the continuous friction which sheds off the scales. So we just see the redness. We have a type which is called the gutted psoriasis, which we just discussed, associated with streptococcal group A infections. Gutted psoriasis associated with streptococcal group A infections, and here it looks like rain has dropped upon the back of someone. So if you go in the rain and the rain falls on your back, and after you come to your home, you remove your shirt and you see the pattern which the rain makes on your shirt, that is a pattern of gutted psoriasis. Pustular psoriasis is a psoriasis with a lot of pustules. You will slowly build upon these concepts and understand more. This is associated with pregnancy, and pustular psoriasis can either occur de novo or upon a psoriasis. So already existing chronic plaque psoriasis can develop pustulation, not on the plaques, elsewhere. So this is associated with IL-36 receptor mutation and a lot of other mutations which might not be important material. As well as there is another type of psoriasis which is called the erythrodermic psoriasis. So remember this and this. These two psoriasis can be triggered by sudden withdrawal of steroids. So which steroids are actually not given usually in psoriasis. So if someone gives them and you suddenly withdraw them, can cause pustular psoriasis or erythrodermic psoriasis, and it can be due to application of irritant like anthralin, coal tar. We will discuss about them in a bit. Even due to phototherapy. So irritants. So basically, these are serious conditions. Erythrodermic psoriasis and pustular psoriasis are serious conditions. These are the very few conditions which require IPD admission in dermatology. They can present with distributive shock, third space loss, and even ICU care. With management with keloids, continuous vital monitoring, treatment of comorbidities, and even prerenal failure. So the other thing which can be involved with the psoriasis, which we will discuss, is joints. So psoriasis has a joint involvement which is Ra negative and HLA-B57 positive. So there is a classification of joint involvement in psoriasis which is called Moll and Wright classification. In this classification, the psoriasis is classified as distal interphalangeal type, distal interphalangeal type, RA-like, asymmetric, oligo and polyarthritis, mutilance, and ankylosing spondylitis, which is drama. So this distal interphalangeal arthritis presents with a penicillin cup appearance, in which the middle phalanx telescopes into the distal phalanx, and it appears as if some pencil has gone into a small cup. RA-like does not involve the DIP, which is seen in classical case of rheumatoid arthritis. And this asymmetric poly and oligoarthritis is the most common pattern. DIP like interphalangeal arthritis is associated with nail involvement.